experience with, except on your rotation over at NYU, but we'll try to give you just the basics. So essentially, this will give you a vocabulary. So when you go on your rotation, you're dealing with liver transplant, you'll at least become familiar with the terms and general principles. So we're going to, again, look at the overview of the indications for liver transplantation, identify and be able to treat complications associated with liver disease in the preoperative period. We're going to look at the identification and treatment of complications following transplantation. We will hear something about the diagnosis and treatment of graft rejection. And at the close, we'll talk about what is a very important issue in the post-transplant state, that's lymphoproliferative disease. So let's get started. The first orthotopic liver transplant was in 1963. There are approximately 5,000 in the US and 500 pediatric annually, but the need is much, much greater than that. The indications for transplant include acute and chronic liver failure due to almost any cause, and we'll look at some of the contraindications later on in this session. If we look at the diagnosis across all age groups who ultimately undergo liver transplant in the US, hepatitis C remains at the head of the class, followed by alcoholic liver disease, autoimmune liver disease, primary biliocirrhosis, primary sclerosing cholangitis, acute liver failure, Hep B, metabolic disease, cancer, and others. So what's missing from this list when we're talking about pediatrics?
Biliary atresia?
Biliary atresia. So if we look at in pediatric liver transplant, the most common reason for transplanting is biliary atresia, followed by genetic and metabolic causes. Then in terms of known diagnoses, acute liver failure, tumors, and cirrhosis, chronic liver disease, cirrhosis that's not biliary atresia related. And of course, there still is a significant group that is unknown or other. We can further break down the indications for liver transplant in pediatrics according to age group. So in the neonate, the primary indication would be neonatal iron storage disease. That has been the ability to transplant these babies has been greatly increased by the development of techniques for partial liver grafts. Of course, in the neonatal period, there's an increased risk for infectious complications. And as we'll talk about later, the major problem with the neonatal liver transplant is the problem post-transplant of vascular thrombosis, obviously related to the size of the vessels that you are connecting. Outside of the neonatal period, up to 50% of those who receive a transplant is secondary to biliary atresia. But then we have to look at the metabolic disorders, either as presenting with acute liver failure or as chronic liver failure from cirrhosis. And that would include Wilson disease, alpha-1 antitrypsin, tyrosinemia, Crigler-Najjar type 1, of course, and a variety of mitochondrial disorders. And we'll talk about the specific mitochondrial hepatopathies later in the year. Other reasons for pediatric liver transplantation would be the PFIC syndromes, and then those patients with chronic liver disease who develop cirrhosis if they show evidence of functional hepatic decompensation marked by coagulopathy, ascites and hemorrhage, malnutrition and growth failure, and frequent infections. So this is a group where the likelihood of undergoing transplantation will be clearly dependent upon the progression of cirrhotic-related liver disease. The major concerns in trying to evaluate and manage patients with liver disease who may require transplantation is candidate evaluation. What are the determinants that are going to lead you to recommend transplantation? The problem also is the waiting period. We generally work through the United Network for Organ Sharing, or UNOS. This is the governing body for organ allocation, and they utilize the MELD or PELD score, which we will review. Medical urgency is obviously a problem, as is the waiting time prior to the ability to perform transplant. And then we have the surgical availability and the problem of post-surgical care. So we'll look at all of these variables. Well, the model for end-stage liver disease, or MELD score, was first developed to evaluate end-stage liver disease in patients 12 years of age or older. The MELD score quantifies the risk of death within 3 months. The higher the score, the higher the mortality, and the range is between 10 and 40. And we'll look at that more closely. And then there are special consideration. Amendments for hepatocellular carcinoma, for example. Patients with HCC, for example, may undergo transplantation without going into liver failure just based on the diagnosis. And of course, then patients with renal failure, either pre or both pre and post transplant, becomes a real problem. The
Do
PELD
we need to know?
score.
I'm
Yeah,
so
go
sorry.
ahead.
These formulas for the boards.
You do
Like
not need
remember
to know
them.
these formulas for the boards. No,
Okay.
no. You
Okay.
need to know what they are, but no one's going to ask you to do this. All right.
Okay.
But what you do need to know is how these scores are utilized to determine who gets transplanted. And so the PELD score, which is shown here, which different, if you look at the MELD score, it's bilirubin plus INR plus creatinine. The PELD score for patients less than 12 years of age, look at bilirubin, INR, albumin, and also a factor for growth failure. And the question always arises, do pediatric end-stage liver disease, or PELD scores, adequately estimate mortality among pediatric patients? Can you predict on the basis of the PELD score who is likely to die within a 90-day period before transplantation? And so this systematic review looked at initially over 6,800 transplant candidates between 2002 and 2010. The final cohort, when you went through all these exclusions, was about 4,300, and then the final reduced cohort that could be used for a systematic review was 2,400. So let's look at that. Now, when you look at this curve, I don't want you to concentrate on the individual scores, but look at the trend. We learned when we talked about acute liver failure and the PELD score that most patients who undergo transplantation, remember that sine curve that I showed you, once the score got to 15 to 20, those were the patients that were most likely to undergo transplantation. And this is why. Here's the PELD score on the x-axis, and the y-axis is the probability of 90-day death without transplantation. And as you can see with the red arrow pointing down, once the PELD score gets above 20, then you start to see a significant rise in your risk of death prior to transplantation for virtually all of these scores. Whether you're looking at the shaded areas of the 95% confidence interval. And here is the interval for the full score, for the full cohort and the reduced cohort. But in any case, if you look at the trend, this is basically why we transplant these patients with a PELD score between 15 and 20. Because beyond that, higher than that, once you get above that level in the PELD score, your risk of death prior to be able to undergo the transplantation significantly rises. Despite all of this, the mortality rate for children on the UNOS waiting list is about 17%. So, despite our ability to determine who should undergo transplantation, the availability of livers and surgical sites for transplantation is going to be a rate limiting factor and still is. What about the contraindications for transplantation? Well, they're shown here, both absolute and relative. The absolute contraindications include hepatocellular carcinoma with metastases and rapid progression, a generalized extrahepatic malignancy. The exception, and this you may have to know, is hepatoblastoma with isolated pulmonary metastases. This is a group that has a favorable prognosis, and this is a group that may undergo transplantation. Patients with uncontrolled infection, with multi-system mitochondrial disease, Niemann-Pick type C, and severe portal pulmonary hypertension not responsive to medical therapy. Those would be your absolute contraindications. What about the relative ones? We go back to hepatocellular carcinoma with venous invasion. In this case, these are patients who may present with Budd-Chiari syndrome, or those who have rapid progression despite chemotherapy. If there's a high certainty of non-adherence, patients with hemophagocytic lymphohistiocytosis and other sort of circumstances that may not be amenable to either adherence or follow-up or other perioperative characteristics. So again, the relative contraindications are relative and depends on individual patient evaluation, but the absolute ones have really remained fairly consistent. So when do you refer patients to a transplant center? Well, again, patients with chronic liver disease, most commonly those who have persistent hyperbilirubinemia. For example, we learned in biliary atresia following Kasai procedures, those patients who remain hyperbilirubinemic in the postoperative period are those almost 100% likely to require liver transplantation at some point. Patients who have metabolic disease poorly controlled by medication, cirrhosis for any reason, again, this is where your MELD or PELD score comes into play. Keep in mind that early referral allows for maximum preoperative management in order to try to limit progression of disease and manage ascites, bleeding, hepatorenal syndrome, allows one to engage in aggressive nutritional management, provide essential immunizations. Remember, patients will be undergoing immunosuppression following transplant, and you want them to be fully immunized whenever possible. So, why am I showing this slide?
Because when we transplant the liver, it's usually one lobe that we transplant, and then if we're taking the donor from an adult, it might be too big for the child, and then there's different procedures that you do, like open versus close. I think maybe because of that.
Correct. The reason I'm showing this is to deal with the split liver transplant. This is one of probably the greatest advance in liver transplantation that has allowed us to use the living related donor. And so if we look at the living related donor, generally the liver is split as this, and it's generally lobes 2, 3, and 4, which are transplanted. So what happens to the donor when we take out half the liver?
Regenerates.
How quickly?
I think it's about 3 months.
3 cell cycles. 3 full cell cycles, and the liver is completely reconstituted. But this is something you'll probably have to know for the boards. In the split liver in a pediatric patient, The segments that are utilized for transplantation are segments 2, 3, and 4. Now, in the keep in mind again that the greatest advance has been the ability to use the living related donor. This figure looks at the incidence of graft failure related to whether you have a deceased donor, that's DDLT, that's the solid line, versus living donor, that's the dashed line. And as you can see, there's a significant difference over time in graft failure, up to 10 years, between the living and the deceased donor. So whenever possible, the living donor liver transplant is always preferred. And the significance, as you can see here, is 0.001. And the same is true for patient survival. Again, the deceased donor is the solid line, the living donor is the dashed line, and note the significant difference 10 years out between the two. Once the transplant is performed, we have to consider what the postoperative complications are going to be, and they're shown here. Primary non-function, hepatic artery thrombosis. This is particularly a problem in the neonate. A portal vein stenosis or thrombosis, biliary leak or biliary obstruction, which is of this group the most common complication. And then we have the problem of rejection. And we'll talk about acute and chronic rejection. And of course, in the immunosuppressed patient, infection. Primary non-function would be marked by the early appearance of encephalopathy. Again, the younger the patient, the more difficult this is to assess, and coagulopathy. These patients may also develop progressive renal and multi-serum system failure, and the marker for that would be an increase in serum lactate levels, rapidly rising liver enzyme, histologic evidence of hepatocyte necrosis. And again, we'll see later how primary non-function and hepatocyte necrosis is going to be the seminal event, which is going to result in a wide variety of problems distant to the liver, including pulmonary and renal problems. And then in those patients with suspected primary non-function, biopsy will show histologic evidence of hepatocyte necrosis without a vascular complication, such as hepatic artery thrombosis. There are risk factors in the donor that are more commonly associated with primary non-function. Prolonged cold ischemia time, the donor, him or herself, being unstable. This is a living donor, of course. A high level of steatosis in the allograft, an older donor, a high serum sodium level in the donor, which suggests some problems with organ function. And again, a recovered organ from a deceased donor after cardiac death. That would be someone where you remove the liver in a deceased donor who has a non-beating heart. So those are the donor risk factors which can predict a higher likelihood of primary non-function of the graft. Hepatic artery thrombosis will be identified initially by markedly escalating AST, ALT, the presence of metabolic acidosis, and fair synthetic function. So not necessarily a gross coagulopathy. Remember that the hepatic artery is the sole blood supply for the biliary system, so a biliary leak will be very common in patients who undergo hepatic artery thrombosis. And then late hepatic artery thrombosis, because this can occur later on in the postoperative period, will lead to multiple biliary strictures. Again, for the same reason, the hepatic artery is the sole blood supply for the biliary system. One can use an ultrasound or arteriography to confirm hepatic artery thrombosis. And those patients who succumb to hepatic artery thrombosis One can do a thrombectomy urgently, or in some cases, retransplantation may be required. Portal vein stenosis or thrombosis, again, not surprisingly, would result in recurrent variceal bleeding with an enlarging spleen, not necessarily the liver, the development of ascites or liver allograft dysfunction. Again, we diagnose by ultrasound or by venogram, and treatment would be surgical intervention in the early post-liver transplant period. And you can do portal vein angioplasty with or without stenting later in the period. So again, whenever you start to have evidence of some dysfunction, one has to go through the algorithm of, do the ultrasound. You may require a biopsy. Look at your lab values to try to determine what the complication is likely to be. Biliary complications, anastomotic leak, again, this can be related to a surgical problem or related to a poor related to a poor anastomosis or hepatic artery thrombosis. And again, the treatment would be immediate exploration to repair the leak. The stricture or obstruction, again, would be most commonly related to hepatic artery thrombosis later in the postoperative period. Again, the evaluation by ERCP or PTC. And when one sees an elevation of bilirubin, alk phos, or GGT, while this is nonspecific because it can be seen in ischemic graft injury or recurrent infection, again, one also has to evaluate for biliary complications. I hope I don't lose my voice. I'm sorry. Now, aside from this, we have the problem of acute rejection. Acute rejection is defined as rejecting the organ within 3 months post-transplantation. These patients will present with fever, graft enlargement, abdominal tenderness, and evidence of reduced bile flow. The first laboratory manifestation will be an elevation in your transaminases. And these patients are diagnosed by liver biopsy, which will reveal portal inflammation, bile duct damage, and evidence of neutrophil and lymphocyte invasion into the blood vessels. Acute cellular rejection is one of the main post-transplant complications affecting graft function. The incidence of acute rejection in children following transplant has been reported between 20 and 50% based on recipient age. In older children, it's more frequent. And here it is. This is a portal area. If you can look closely at this, you see a mixed inflammatory picture. There are neutrophils. There's one. There's a band cell here. Lymphocytes. This is probably an eosinophil here. So you see a mixed inflammatory picture. Again, the inflammatory reaction is so severe, you really cannot identify any vascular or biliary structures. The treatment of acute rejection would be immunosuppression and includes both steroids and anti-thymocyte globulins. Now, this may be used initially in the post-transplant situation, depending on the center and depending upon the algorithm that they use for treatment. But when acute rejection is suspected, steroids and ATG are the hallmarks of therapy. Chronic rejection would hopefully be a problem that should not be seen frequently because most cases shown at the bottom are the consequence of medication noncompliance. Histologically, you see the loss of small bile ducts. It's called ductopenia, and that's the most important diagnostic feature. And you can also see an obliterative vasculopathy, again, as the inflammatory cells destroy the portal area. And so here we see an evaluation histologically in a patient with a chronic rejection. Here you see, again, a lot of inflammatory cells in the portal area. You see a thickening of the wall of the pulmonary artery, I'm sorry, of the artery here, and again, portal artery here. Again, this is related to inflammatory infiltration. Here's another artery that's about to be obliterated. Here's a vein you can't even see. Where's the bile duct? There is no bile duct. So again, this is a ductopenic chronic rejection. And here's another view of a patient with chronic rejection. Again, this can be a mixed inflammatory picture. So you can see some eosinophils here as well. This is not a bile duct. This is actually a rosetting of hepatocytes, which is a response to the loss of bile ducts. So again, this is ductopenic rejection with a mixed inflammatory infiltrate. And again, this is chronic. This is occurring more than 3 months out post-transplantation. Infection, of course, is going to be a problem in the post-transplant period. Early infections are generally enterococcal or staphylococcal, although yeast can also be seen. The intermediate period is the peak for donor-related. This is CMV. And again, this is when you're first going to see a post-transplant lymphoproliferative disorder related to a reactivation of Epstein-Barr virus infection. And this is also where you're going to see opportunistic infections like pneumocystis. Late infections after 6 months are related to problems with the biliary tract primarily, including recurrent bacterial cholangitis. And this is again the period where you'll also see post-transplant lymphoproliferative disease. Well, despite all of these horrible post-transplant situations, keep in mind that the long-term outcomes have improved dramatically over time. The 1-year survival for children in the post-transplant period over all ages approaches 90%, and the 5-year survival approaches 80%. So our ability to identify and manage these complications in the post-transplant period have allowed for a really dramatic improvement in survival with these percentages that you see in this slide. Again, I mentioned earlier the difference between the deceased donor and the living donor. Again, this is perhaps a simpler way of looking at it. This is graft failure from 6 months out to 10 years, and you can see obviously the differences between the deceased donor and the living donor. So now we turn to the area that you will probably want to know something about in terms of your rotation over at NYU, and that is, how do we deal with post-transplant immunosuppression? It's really a question of induction of immunosuppression and maintenance of immunosuppression. So these medications can be classified as either induction or maintenance agents. Induction therapy involves potent immunosuppression in the immediate post-transplant period, and that reduces the initial really robust immune response of your T lymphocytes. Therapy for induction is often initiated intraoperatively or immediately postoperatively, and generally takes place over a 7 to 10 day period from the time of transplantation. The most common agents include antithymocyte globulin and interleukin-2 receptor antagonist. Basiliximab is one of them, and we'll say more about these, and I'll show you exactly how they work in subsequent slides. So we have the induction, and then we have the maintenance therapies. The maintenance therapies, there's a whole laundry list of them. Just be familiar with the names, and again, I'll show you how they work. They include the calcineurin inhibitors, cyclosporin and tacrolimus, sirolimus, azathioprine, everolimus, mycophenolate mofetil, and corticosteroids. And then we have down here, I've showed you the induction, and then there's the anti-rejection therapy, and one of them being anti-CD3, umuronimab. The
Is there
anti-rejection, yep,
is there a gold standard amongst these? Because all of the
no.
patients that I saw during my rotation were all on Tacro.
There, tacrolimus is maintenance therapy. Uh, so tacrolimus has really sort of supplanted cyclosporin as the main post-transplant immunosuppression, largely related to there are fewer side effects with tacrolimus as opposed to cyclosporin, and again, levels don't have to be measured quite as closely. But all of these drugs are used. There is no standard protocol. There is a standard protocol in each individual center, but they can vary from center to center.
Thank you.
The anti-rejection therapy can suppress immunocyte gene activation and cytokine production. Again, that's the most common range of therapies and includes the corticosteroids and the calcineurin inhibitors. They can directly modulate the immune response through inhibition of the mammalian target of rapamycin. That's where everolimus and sirolimus are used. They can inhibit DNA replication and the expansion of clones of lymphocytes, MMF and the thiopurines, or they can block T cell migration to the effector sites. And this is where your induction therapy comes into play, using anti-thymocyte globulin and the anti-IL-2 receptor. So here is the figure that deals with all of them. So let's first go to the upper left, corticosteroids and mironimab, which is an anti-CD3. They prevent the antigen presenting cell from hooking on to a toll-like receptor, a T cell receptor on the lymphocyte surface. So again, it avoids this whole cascade leading to the proliferation of T lymphocytes and again, proliferation of killer cells. Then we have cyclosporin and tacrolimus. They're calcineurin inhibitors. So instead of acting at the cell surface, they act intracellularly, again, inhibiting the same pathway. You can get further deep into the pathway by directly inhibiting the cell cycle of the lymphocyte. That's where azathioprine and MMF come into play. And you can use mycophenolic acid or leflunomide here. They directly block nucleotide synthesis. Sirolimus and everolimus, again, as well as basiliximab, this is the pathway that they inhibit. Again, basiliximab being an IL-2 receptor blocker at the cell surface, so it ultimately prevents, again, the stimulation of mammalian target of rapamycin, which is a pro-inflammatory, pro-cell proliferation agent. And then sirolimus and everolimus, again, block the mammalian target of rapamycin. And again, here's IL-2 the same way, which will lead to increased cytokine production. So again, one can choose any of these pathways. You should have a basic understanding of how these agents work. But as Dr. Khan pointed out, individual centers will have their own particular course of therapy for patients. Corticosteroids, again, complex with intracellular receptors that bind elements and prevent activation of genes needed for the immune response. So it prevents ultimately the production of IL-2 and interferon. The corticosteroids suppress proliferation of helper and cytotoxic T and B cells, and they inhibit migration and activity of neutrophils. But obviously, corticosteroids are only a short term, whenever possible, again, related to the profound side effects related to corticosteroid use. The calcineurin inhibitors, they're absorbed in the small intestine. Keep in mind that the absorption of cyclosporin, but not tacrolimus, is dependent on bile acids. Another reason why tacrolimus would be preferred. Cyclosporin absorption is increased when ingested with a fatty meal. Tacrolimus is decreased with meals. And both of these drugs are metabolized by your cytochrome P450 system, and their metabolites are excreted in the bile. They're both associated with side effects. Again, dose-dependent hypertension for cyclosporin. Cyclosporin is a nephrotoxic agent. It's also a neurotoxic agent and associated with multiple other complications. Again, you have to be mindful of what drugs a patient is on because cyclosporin levels will either be increased or decreased depending upon what other drugs the patient is on. So again, this has to, when any transplant center will have to be aware of this so that they can monitor levels if patients are on any of these drugs to either increase or decrease levels. But again, as Dr. Khan mentioned, cyclosporin has largely been supplanted by tacrolimus. The importance of tacrolimus has side effects, but they're less than with cyclosporin. One does have to measure trough levels to monitor the dose. Keep in mind also that the clearance of tacrolimus is 2 to 4 times faster in children than adults, so children will require a relatively higher dose of the drug. Tacrolimus also causes a dose-dependent nephrotoxicity and neurotoxicity as well as hypertension, but it tends to be less than with cyclosporin. The other complications and side effects are shown here. Hyperglycemia and hyperlipidemia. Hyperglycemia is more of a problem than with cyclosporin. Hyperlipidemia is less of a problem. And when tacrolimus is co-administered with steroids, that can actually exacerbate these side effects. Electrolyte problems can also occur. Hyperuricemia, again, but that's less than cyclosporin. Again, when patients are on these drugs, simple blood tests should be used to monitor them in order to evaluate for potential toxicity. Just like cyclosporin, tacrolimus levels can be influenced by co-administered drugs, increased to the left, decreased to the right. Grapefruit juice, of course, just like statins, grapefruit juice, again, because of the effect on the cytochrome P450 system, will increase levels for both tacrolimus and for cyclosporin. MMF, the drug I showed you earlier, and I'm going to go back here, not to give you a seizure, but to show you where MMF works. Here we have MMF inhibiting the cell cycle. Is the active metabolite of mycophenolic acid. It is a selective inhibitor of inositol monophosphate dehydrogenase, which is an essential enzyme in the synthesis of purines, the building blocks of nucleic acids, and accordingly it arrests lymphocyte replication and can be used as alternative therapy in chronic rejection or in patients who have calcineurin inhibitor toxicity. And here's a schematic of how it works. It blocks inosine monophosphate dehydrogenase, leading ultimately to nucleic acid synthesis. If you can't make nucleic acids, you can't make DNA. And in this case, when it gets into the lymphocytes, it arrests replication. MMF is metabolized by esterases in the gut wall, and it undergoes an enterohepatic circulation. And because it undergoes an enterohepatic circulation, because the glucuronide is reverted to mycophenolic acid by gut flora, there's a secondary peak in the blood. So again, one has to be mindful of this when monitoring drug levels. It also has adverse effects, not surprisingly, bone marrow suppression. Diarrhea is a problem with MMF and is a major dose-limiting side effect. Unlike the calcineurin inhibitors, it has no effect on glucose metabolism. Again, a variety of agents that affect the enterohepatic circulation, cholestyramine, antacids, are going to reduce MMF levels. Antibiotics reduce gut flora and will reduce enterohepatic circulation, thus blunting that secondary peak. Remember, if any patient on cholestyramine, it binds to it. So again, depending on the drug, one has to be aware of what the side effects are. And if you're aware of the side effects are, you can tailor therapy accordingly. Sirolimus is a macrolide antibiotic. It's used generally in conjunction with tacrolimus to reduce acute rejection and facilitate steroid withdrawal. It's also used in rescue therapy of chronic rejection and in patients with calcineurin toxicity. Remember, this works through the mammalian target of rapamycin, which inhibits it. The mTOR is responsible. It's a pro-proliferative agent. And again, sirolimus levels will increase with simultaneous administration of cyclosporin A. Antibody preparations are generally lymphocyte depleting, and those are anti-thymocyte globulin, or they can be non-lymphocyte depleting, directed at specific cytokines or receptors, in this case, the IL-2 receptor antibody. IL-2 receptor antibodies include basiliximab and daclizumab. The indications are for induction directly after transplantation and as adjunct therapy to allow one to decrease the dose of calcineurin inhibitors, which are nephrotoxic, in patients who may have delayed graft function. They're not effective in acute rejection. They're well tolerated. Now, IL-2 is a pluripotent cytokine that influences a wide variety of T cell proliferative activities, but it targets only those cells who have CD25 as a surface antigen. It has no effect on resting T cells. And this sort of shows you what IL-2 does. It can stimulate T regulatory cells. These are CD25 negative cells, but it can also stimulate naive CD4 and CD8 cells that have increased CD25 expression. When you have these cells and you stimulate them through IL-2, you then produce CD4 positive, CD8 positive cells with increased CD25 expression. These are your helper or killer cells, producing both from a antibody production standpoint and from a T killer cell standpoint. So by inhibiting the IL-2 receptor, you then inhibit the ability to produce more CD4 or CD8 positive cells, leading to reduced antibody production and reduced cellular proliferation. OKT3 or mironimab is a mouse anti-human CD3 specific antibody, which impairs T cell activation and proliferation. It can induce a cytokine release syndrome because of T cell destruction, releasing a wide variety of cytokines into the bloodstream. So cytokine release syndrome is associated with numerous chemotherapeutic agents that are used essentially to manage a variety of cancers, but also cytokine release syndrome as an immunosuppressive agent in the post-transplant period with OKT3 can induce a cytokine release syndrome. And when this happens, because of its profound effects, it is associated with an increased incidence of post-transplant proliferative disorder, and OKT3 is most commonly used for rescue therapy in patients who have chronic rejection. And here is how it works. Again, it targets those cells expressing the cluster differentiation marker CD3, prevents the antigen presenting cell from hooking on to the T cell and activating it. So keep in mind that when you have either rejection or primary graft function and you have necrosis of hepatocytes, this leads to graft necroinflammation and the release of all of these toxic cytokines and chemokines into the bloodstream, which can lead to a remote organ injury. This is why patients with rejection or graft failure also have to be monitored for kidney injury, lung injury, and also intestinal injury as well. And because you have all of these necrotic products spreading into the bloodstream, it also will lead to both secondary innate immunity and an adaptive immune response. We talked about these responses previously. Again, that is going to increase the likelihood of allograft dysfunction, primary graft malfunction, and rejection. So again, the target here is to prevent T cell proliferation, prevent the release of cytokines and chemokines whenever possible, so as to reduce the likelihood of either circling back to the liver and inducing necroinflammation or leading to remote organ injury. But of course, one of the problems that we have to be most mindful for is PTLD, or post-transplant lymphoproliferative disorder. This is an aggressive complication of solid organ and hematopoietic stem cell transplantation that arises in up to 20% of transplant recipients. PTLD results from either primary infection or reactivation of EBV, which is a ubiquitous herpes virus. And when you have reactivation in combination with chronic immunosuppression, that leads to PTLD. PTLD, again, results from EBV infection in the setting of immunosuppression. It is the most frequent proliferative event leading to tumor formation in children following liver transplant. It generally occurs in the first 2 years post-transplant. Risk factors include a high immunosuppressive load. If patients are given more immunosuppressive drugs because of the problem of rejection, a patient who has never seen EBV before, and of course, what is the viral load that the patient is presented with. So this is the classification of PTLD. Early lesions at the top is just a plasmacytic hyperplasia and a lesion which looks like mononucleosis. Later on, one can develop both B cell neoplasms and T cell neoplasms. And of course, it can also lead to a classic Hodgkin's lymphoma type. So initially, clonal expansion, proliferation of lymphocytes. If this goes unchecked, it can lead to frank B or T cell neoplasms. And this is why it happens. One has a primary infection with EBV. Now you have in the normal individual, you have a naive T cell, it senses this, and you have a primary cytotoxic lymphocyte response that destroys your EBV infected cells. But if that is not fully killed, then you have persistent infection. So now you have an EBV infected B cell, and that can have clonal expansion, but you again can have a secondary cytotoxic lymphocyte response, which selectively will destroy EBV infected cells. And this can occur in the normal individual without the development of any overt disease. But what happens when you immunosuppress? When you immunosuppress, you are unable to engage in this secondary lymphocyte response. So you're not able to kill off your EBV infected cells. Well, if you can't kill off your EBV infected cells, you get chronic stimulation, you get a cytokine imbalance, you have further immunosuppression, you have clonal expansion, here's your PTLD. And if this goes unchecked, the consequence likely will be the development of one of these lymphomatous complications I showed on the previous slide. And this is what it looks like. Again, I've showed you slides before of lymphomas. They tend to be sort of boring looking. And again, you see here clonal expansion, replacement here of whatever tissue this is. I think it's liver, by the expansion of the clonal expansion of these lymphocytes. The symptoms: fever, lymphadenopathy, enlargement of lymphoid tissue, splenomegaly. You may have abdominal masses. How do you treat PTLD? Well, remember that the PTLD, the problem is immunosuppression. So in patients with PTLD, you want to immediately decrease or discontinue immunosuppression. But it's a double-edged sword. So at the same time, you may be effectively reawakening your memory cells to kill the EBV-infected cells. It also would increase your risk of rejection. One can also use specific chemotherapeutic agents like rituximab, which is a B cell monoclonal antibody. In severe cases, you can use a variety of agents, and you can also transplant patients. This is called CAR T cell therapy with EBV prime T cells, which are allogeneic and can be infused and directed against EBV infected cells in the host. So, what have we learned by our lectures in liver failure and liver transplantation? First and foremost, a multidisciplinary transplant team should be skilled in pediatric conditions and properly communicate with the family and the child the processes, risks, and benefits associated with liver transplant. When you have a patient in whom the clinical course may lead to liver failure and the need for transplantation, one should immediately contact the transplant center in order to have them aware of what the problem is and be able to emergently transfer patients when required. Keep in mind that children with liver-based metabolic crises refractory to medical or surgical therapy, unresectable hepatoblastoma, or evidence of unresectable hepatocellular carcinoma should be referred urgently. These are the ones who may immediately require transplant prior to the development of overt liver failure. Again, biliary atresia patients who are post-Kasai procedure should be referred to a transplant center if they remain hyperbilirubinemic. Remember, when the bilirubin is above 2, 3 months out, that is highly significant and would suggest that ultimately that patient is going to go into liver failure and may require and will require transplantation. And this is 2/3 of your patients who undergo Kasai procedure. Referral for transplant should be anticipated for children with chronic liver disease and evidence of deteriorating liver function, including everything on this list that we've talked about. The leading cause of liver disease leading to transplantation in early childhood is cholestatic liver disease, biliary atresia. In older children, metabolic and autoimmune diseases predominate. The standard protocol for immunosuppression, again, I discussed this with Dr. Khan, in the immediate post-transplant period may vary. Current maintenance therapies include a calcineurin inhibitor, most commonly tacrolimus, plus a corticosteroid and MMF. IL-2 receptor antibodies are critical adjunct agents to prevent early rejection and are generally used in the immediate post-transplant period. Keep in mind that the complications refer not only to rejection and liver disease, but can reflect remote organ failure. And later on, a malignancy is most commonly associated with PTLD, and that's usually the result of donor-transmitted EBV infection. Patients with indeterminate or autoimmune hepatitis, when these patients are transplanted, keep in mind that that problem may recur in long-term transplant survivors 10 years out or longer. This is not true of the biliary atresia patient or the metabolic disease patient, but is particularly true for the patient who undergoes transplantation for autoimmune hepatitis. And of course, we want to limit corticosteroid use for obvious reasons. That's a lot of information for you guys to digest. I'm not suggesting that you need to remember any of this, but I hope that you've gained some familiarity so when you go on your rotation, you'll be able to recognize the vocabulary and hopefully give you a start.
Thank you.
And that